Welcome, everyone. Thank you so much for joining us here today for yet another installment of the Virtual Grand Rounds series. My name is Jessica Fern, and I am the Director of Global Health Impact here at CanWatch, the Canadian Partnership for Women and Children's Health. And we are so excited to be serving as the coordinating center for the Pan-Canadian Women's Health Coalition, which is a remarkable network of 10 incredible research teams and community partners across the country that are working in critical areas of women and gender diverse people's health research. Today's conversation is with one of those incredible partners, but of course we invite you to join us every month for a new conversation with a different partner. We'll share a little bit more about that at the end of the session, but in the meantime, it's my absolute pleasure to welcome Dr. Lori Brotto from the SHAPE Hub to kick off today's conversation, Evidence with Impact, Patient-Driven Sexual Health Research. Dr. Brotto, over to you.
Thank you so much, Jessica, and good morning, good afternoon, everyone, depending on what part of the country you're coming from today. I myself am located on the West Coast in Vancouver on the traditional ancestral and unceded lands of the Coast Salish peoples, including the Musqueam, Squamish, and Tsleil-Waututh nations. And as always, we raise our hands and give thanks to the original caretakers of these lands where we live, work, and play, advancing women's health and those of Two-Spirit and 2S LGBTQA+ individuals. So really excited to be able to share some of the work that we've been doing with SHAPE with you today. Next slide, Sundus. You're going to hear from an assortment of members from the SHAPE Hub. And when their time comes, I'll invite each of them to introduce themselves today. But we have a mix of some of our healthcare provider partners, our trainees, our NGO partners, our researchers, and our hope today is really to give you a high-level snapshot about what we've been up to and get you really excited about some of the knowledge mobilization that our team has been undertaking over the past year with SHAPE. Next slide. So what is SHAPE? Well, first of all, it stands for Sexual Health and Genito Pelvic Pain Knowledge Empowerment Hub. And as Jessica mentioned, we were very fortunate to be one of the 10 women's health knowledge mobilization hubs across Canada that were funded by the Canadian Institutes of Health Research from the Institute of Gender and Health in partnership with WAGE. And our mandate is really to mobilize knowledge around the topic area of sexual health and genital pelvic pain. Next. So why this topic area? Well, we know based on large population-based studies that at least 1 in 3 women will report distressing symptoms of sexual dysfunction. So this would include things like distressing low sexual desire, pain with sexual activity, difficulties with orgasm, and that these difficulties are very distressing to individuals and can have quite a profound impact on their mood, relationships, quality of life, etc. And unfortunately, far less is known about the prevalence of these conditions among racialized people, trans women, gender diverse, and Two-Spirit individuals. And that has certainly been part of what we've been looking at in SHAPE is how can we get more awareness and recognition and research around these topics among these underserved communities. We also know that in the topic of sexual dysfunction and genital pelvic pain, that there's a critical need for more healthcare provider training. There's a need to increase knowledge among the general public in an effort to reduce stigma, and that there's a real need around providing timely and culturally safe and trauma-informed care. So that leads us to our core mandate with SHAPE next, which I'll briefly describe for you. So as mentioned, we're a 4-year initiative funded by CIHR and WAGE. We're part of the coalition, and our leadership team includes myself as the nominated principal applicant. I'm a researcher, clinician, and educator in women's sexual health located at the University of British Columbia in Vancouver. Our physician lead, Dr. Melanie Altis, who you'll be hearing from very shortly, and our core NGO partner, SECAN, or the Sex Information and Education Council of Canada, and you'll hear from Jessica representing SECAN shortly. So really our mandate is about connecting the larger ecosystem, which includes clinicians, researchers, policymakers, specialists, patients, trainees, in order to really mobilize knowledge. So we actually do have a good amount of research knowledge on these topics, but a real gap in the knowledge translation. Many of you out there have heard about the 17-year gap. And so we're using evidence-based knowledge mobilization methods to really close that gap and ensure that information reaches the intended audiences. We're very proud of our partnerships with patient partners and persons with lived and living experience throughout everything that we do. And it's been really critical and also really quite wonderful to have our patient partners involved at every step of the design of all of our initiatives throughout SHAPE. Next slide. You can read about our mission at our website, which is shapehub.ca. Maybe I'll ask Kaku, who's our knowledge mobilization manager that keeps us moving in the right direction. If Kaku, you can put the URL in the chat. And so what I'm going to do is I'm going to share with you just a tiny snapshot of one of the things that we've been working at around that first mission, which is around disseminating evidence-based information about these topics to two target audiences, the public and women, as well as to healthcare providers. And all of our materials are translated from English to French as well. So if you were to go to our SHAPE Hub website, next slide, what you would see, oh, sorry, you can go back one slide. I forgot we didn't have a slide to show the materials, but maybe, Sundis, I'll ask you to put the URLs in so that people can see. So in partnership with CCAN, we launched on World Sexual Health Day, which was September 4th of this year, our portal. And this is something we've been working very, very hard at over the last year. And these are accessible resources that live on the CCAN website that target healthcare providers and women in the public. So I'm going to give you a snapshot of one of them right now. And Sundis, are you able to bring it up on the slide for everyone to see? So essentially what we did is we took published material on these topic areas and created, so it's actually the two links. Yeah, so not the SHAPE Hub, but the actual links of, yeah, there we go. Perfect. So here's a snapshot of one of them. And for sake of time, I'm going to go very quickly through it. So this is a tool that's for patients. And so this is for individuals, women and gender diverse people who are in the postpartum period and might be experiencing some pelvic floor difficulties. These are symptoms that are very common in the postpartum. And this is essentially a translation of an evidence-based and published article that new parents can use themselves to identify if they're having pelvic floor difficulties. So if you scroll down just a little bit, you'll see that there's a series of questions that people can ask themselves. They can fill out this questionnaire, and then they can use the information to guide what they might say to a healthcare provider and whether they should be seeking treatment or not. If you scroll down just a little bit further, you'll see that there's a very lay-friendly scoring translation of this document. So this is just one example of many that's targeting the knowledge user, so the patient, the woman, the gender diverse person. The other link, if you can bring it up now, Sundis, is for healthcare providers. And this also is a document that's been translated from a peer-reviewed publication, a much more extensive document that really is targeting the primary care provider, the healthcare provider who doesn't have extensive knowledge in identifying or managing sexual dysfunction. And we have snapshots of language that the healthcare provider can actually use in clinic with patients. And then if you scroll down a little bit further, a very helpful flow chart that helps guide their management. So if the person has physical concerns that they're mentioning, it takes you down one section of the flow chart and additional steps that the healthcare provider might undertake, versus if they don't have physical complaints, it takes you down a separate section of the flow chart. And so our hope with documents like this is, number one, that we get healthcare providers and the public very interested in these topics of sexual dysfunction and genital pelvic pain, but also enhance their management and identification of these concerns. given that the vast majority of people with concerns will present to primary care, and that's where we really see one gap. So these are two very quick snapshots of some of the tools that we have at our portal located on the CCAN website, but we really invite you to spend some time there to share the site with people you know that might benefit from it, including healthcare providers, including people with lived experience, so that we can ensure they get access to the care that they need. So with that, I'm very happy to turn the floor now over to our NGO partner, Jessica Wood, who represents CCAN. Over to you now, Jessica.
Thank you, Laurie. Hi, everyone. My name is Jessica. I'm the Director of Research and Policy Development at CCAN, which is the Sex Information and Education Council of Canada. We are thrilled to be the NGO partner on this project. I think the SHAPE Hub really brings together people across sectors, across regions, and it addresses, as Laurie noted, a very critical sexual health information and resource gap for people who experience genitopelvic pain and the healthcare providers who are helping them and providing important information for them to make decisions about their sexual health and well-being. And as Laurie also noted, you can find the SHAPE Hub portal and its resources on our website, and there are so many incredible ones there that I really encourage you to take a look. Next slide. Thank you. So CCAN is a not-for-profit charitable organization that seeks to promote sexual and reproductive health in Canada. We're an interdisciplinary team that works with a variety of partners across the country and across sectors to develop, disseminate, and evaluate sexual health education and sexual health promotion resources for different audiences, including healthcare providers, teachers, the public, or researchers and trainees. We do a lot of different sexual health promotion activities, whether that's resource development, research, or policy and curriculum consultation. We have a lot of different materials that we create for teachers, for healthcare providers, whether that's guidelines or fact sheets or videos. And a lot of these kinds of different types of resources are really important for helping people have really accessible, easy access to information about sexual health. Next slide. So I think this is a really important partnership, as CCAN's priorities are well aligned with the goals of the SHAPE project. One of our primary goals is ensuring that people who are delivering sexual health education or providing sexual health information, like educators or healthcare providers, have the knowledge and skills to do so effectively and have access to evidence-based resources that they can use with different populations. And so we're also really committed to ensuring that the public has access to accurate sexual health resources from credible sources, and that sexual health resources are developed with input from different communities that are being served. It's really critical that sexual health resources and programs meet the needs of specific groups of individuals, particularly marginalized and underserved youth, with 2S LGBTQ+ youth, girls and young women, and newcomer youth are being a particular focus for us. And it's really important for us that programs and resources are aligned with the core principles of comprehensive sexual health education. So ensuring that sexual health programs and resources are inclusive, responsive to the needs of the populations that people are working with, and making sure those resources are culturally responsive, evidence-based, and promote gender equality. And I think the SHAPE project, with its approach and materials that have been created, are very much aligned with these core principles in terms of how the project has been conceptualized, the folks that are at the table, how the research and the resources are developed, the engagement with different communities, and the overall dissemination strategy. So I think this is a very important alignment with the work that CCAN does and the way that the project has been developed at every stage. Next slide. So I think together this partnership between SHAPE and CCAN is a really wonderful way to bring networks together and extend them out across sectors and audiences, making sure that resources are accessible and reaching the folks who need the information. The people on the SHAPE team, along with CCAN, have extended reach across the country to a wide audience, which allows us to use established professional and social media networks to disseminate the resources created for the SHAPE Hub. And I think very importantly, we are in a time where misinformation and misconceptions about sexuality and sexual health are very high, and people are looking for credible, trusted sources of information that helps to destigmatize sexual problems and pain, that validates their experiences and makes them feel seen, and helps them make informed decisions about their sexual health and well-being. So the combination of lived experiences and voices, the expertise of the folks involved, and the reach of the NGO partners like CCAN, I think allows for the production of excellent accessible resources and greater reach, amplifying the impact of the project across the country. So I would encourage you to check out the hub, to look at the resources, and then to reach out as well to let the folks on the team know what other kind of educational resources you think are needed in this space as well. So thank you.
Thanks so much, Jessica. We're now going to hear from our tripartite physician lead, Dr. Melanie Altus, who's in clinic right now, serving the population. And so she's pre-recorded a video to share what her perspective has been like and what her priorities are representing our healthcare providers on the SHAPE Hub. So Sundus, you can go ahead and press play.
Hi, everyone. My name is Dr. Melanie Altaz. I'm a gynecologist and sexual medicine physician based here in Vancouver, BC. I'm also one of the co-PIs on the SHAPE Hub. So I'm just going to dive right into my talk. And basically, what I want to do over the next few minutes is to speak to the physician experience and the patient impact of vulvodynia, which is basically pain with vaginal insertion. So I'm not going to review the assessment or the management, but I'm going to explore some of the things that I hear as a physician specialist. And we know that there are a lot of barriers to physicians providing the care they want to, as well for many patients who are trying to find answers. So why is this important? So you would think if there are so many barriers that this must be a rare condition, but that's actually not the case. It's quite common, and it's estimated to impact conservatively 8%, but likely up to 16% of people. We also know that it's underdiagnosed, with 60% of people seeing 3 or more doctors before receiving a diagnosis, with the average time to diagnosis being more than 2 years. That's what the research tells us. I see women who've waited many, many, many more years to get a diagnosis. And we also know that the symptoms of vulvodynia have debilitating impact on quality of life and cause significant psychological suffering. So from a patient impact perspective, we can divide it up into these different headings where we have a clinical impact where people will be guarded during appointments. They may avoid appointments with their physician completely. There can also be a lack of trust in the healthcare system. From a psychological perspective, we can see anxiety, stress about loss of agency, depression, as well as changes negatively in self-esteem. We see an impact on relationships with intimacy withdrawal or avoidance, conflict, resentment, and even the ending of relationships for this reason. We can also see people make different lifestyle choices. So maybe some people decide not to date or enter into a relationship. They may also choose not to have children solely for the reason because sex is painful. So I find that, me listing these things can certainly be impactful, but I'm really drawn to the patient narrative. I love patient stories. I find it very, very powerful. So I'm going to go through and tell you one of my patient stories in her own words. She said, "I had trusted these experts who said it was all in my head. And I believed that if my pain experience wasn't real, then something must be really wrong with me, mentally and emotionally. I was isolating myself because of this shameful secret of PVD. I felt completely alone in this pain and couldn't talk to anyone about it. There was cultural shame and wondering if the pain was a punishment for having sex before I was married, and personal shame from this idea that sex was supposed to come as naturally as breathing, sleeping, or eating, but I kept failing at it. I know you can't change the past, but sometimes I wonder what would be different if it had been recognized and treated earlier when I was in my 20s. So that's pretty powerful, isn't it? So when we hear stories like this, we would naturally wonder, but why? So why are women encountering these barriers within our healthcare system? So first, I'd like to show you this survey that we did at one of our vulvar health conferences. So this was a survey of 117 community providers looking at how comfortable are they diagnosing and treating vulvodynia. So you can tell that there likely is a lot of bias in this because we had people at this conference who were interested in women's health. And even still, we found that there was almost 25% were uncomfortable diagnosing vulvodynia, and almost 70% of primary care providers at a women's health conference were uncomfortable treating vulvodynia. So why? Why is this the case? So all of these barriers were identified during our survey questions. So physician barriers, definitely the main one would be around lack of education and awareness. Many physicians go through medical school and residency without even hearing the word vulvodynia, let alone receiving comprehensive education about it. We have a lack of formal guidelines about the process of clinical care. There's a lack of resources for physicians to give to their patients, educational resources, websites, treatment resources, and also there's difficulties with having an adequate office time to address these concerns. From a patient perspective, the ability to pay for allied healthcare services such as physiotherapy or psychology. But another really big one was patient empowerment and awareness. Many women lack the confidence, the knowledge, the language to advocate for themselves and to have these types of conversations with their physicians. And so that's why what we're doing with the Shape Hub is so important. And it's why knowledge translation matters. So when knowledge exists, but it doesn't reach the point of care, you can see where there would be a really big gap in medicine, and how this is really important for this academic research to get to right to the healthcare providers or the frontline workers. So giving clinicians short, ready-to-use language and framing is not only about education, but it's about access to care and improving patient care. So this is the difference between a 4 or 5 year delay and 4 minutes of validation and normalization. So this is what the Shape Hub has done, is to make those first few minutes of care different for our patients. Yeah, and you can actually feel that shift when someone hears for the first time that your pain is real. I know about this. I've heard about this before, and I'm going to help you. I'm just going to end here with one of the resources that we have in the Shape Hub. So this is called the Vulvodynia Primary Care Toolkit. It's providing resources for community family physicians and other primary care providers to help them provide support to their patients. So basically in diagnosing, education, and early management. So this is not meant to be a comprehensive educational tool to create vulvar or vulvodynia specialists. This toolkit is in the Shape Hub, and also as part of the Shape Hub, we've translated this into French. So I'm going to end there, and I think you'll hear a lot more about the Shape Hub during these rounds. And thank you for attending.
Thank you so much, Dr. Altis. So one of the other things that we've been doing over the course of our time on the Shape Hub is identifying areas that are in grave need of more research and research support. And so to talk about one of those areas, in a moment, I'm going to turn the floor over to another one of our healthcare providers, Yassi Pirani. But in brief, what we've been doing is we've identified 3 topic areas, namely that of Indigenous and Two-Spirit individuals' sexual health and genital pelvic pain, that of Black women's sexual health and genital pelvic pain, and the topic area of post-SSRI sexual dysfunction. And we've been working with community to hear from community what are their priority areas around research. And so to talk about the third area, that around PSSD research, I'm very happy now to turn the floor over to Yassi Pirani.
Thanks so much, Lori. So my name is Yassi. I'm a therapist and researcher, and as Lori mentioned, a Shape Hub healthcare provider partner specializing in PSSD. PSSD stands for post-SSRI sexual dysfunction. I'll be explaining what it is in a moment. Yeah, I work with the PSSD community and help lead the Canadian PSSD Society along with patient advocates. So I'm curious, I know this room has probably a few folks for sure who've heard of PSSD before, unlike some rooms I'm in, but I'm curious to know, we have a little poll exercise. I'd be curious, who has heard of PSSD before? Does anybody know what it is? Yeah, just love to get a, kind of number, a sense of, okay, wow, this is really exciting. We have about half of participants or attendees here who have heard. 48% say yes, 48% say no, and 5% maybe. So yeah, that's really exciting because I think, I mean, for a long time, that kind of statistic in a space would be pretty unheard of. So we're making progress. So I can share a little bit, next slide, about PSSD for those who haven't heard of it or who've just maybe briefly heard of it and don't know a lot of detail. So antidepressant medications are commonly prescribed to help manage symptoms of a range of conditions, including depression, anxiety, OCD, PTSD, and non-mental health related conditions as well, such as sleep problems or IBS even. And post-SSRI sexual dysfunction is a condition where adverse effects of sexual dysfunction arise and persist despite the cessation of these medications. Symptoms can begin while on the medication or can present upon discontinuation. And these symptoms can arise from SSRIs, SNRIs, and tricyclic antidepressant medications. It's PSSD is an under-researched and underreported iatrogenic syndrome, meaning it's caused by a medical intervention. And it can affect individuals of any age or sex. Next slide. Also, PSSD is not dose dependent. It can occur after just a few doses, even in individuals who previously tolerated the medication without issue. I've spoken to a lot of folks who thought they could use SSRI safely, and then they got PSSD the third or fourth time they went on an SSRI. Unfortunately, there's no known cure or effective treatment. And PSSD may be harder to recognize individuals who are prescribed antidepressants during childhood or adolescence because this is due to a limited baseline sexual experience. So it's really, kind of hard to compare. So next slide, please. Key sexual and non-sexual symptoms of the condition. So the name is a little bit misleading in a sense because there's still a lot more going on than just sexual symptoms. Key sexual symptoms include genital anesthesia or hyposthesia or numbness. All the same meaning. Also pleasureless, muted, or absent orgasm, anorgasmia, it's called. Decreased vaginal lubrication, erectile dysfunction, premature delayed ejaculation, reduced or absent sexual desire or response to stimuli, and reduced sensitivity in sexually sensitive areas such as nipples. And there's also a range of non-sexual symptoms, including emotional numbing or anesthesia, and anhedonia, inability to feel pleasure, reward, motivation, or anticipation, depersonalization, cognitive impairment. Oh, sorry, next slide. Cognitive impairment, including severe memory and information retention issues, brain fog, loss of interoception and visualization, and much more. And there's also a range of sensory disturbances involving skin, smell, taste, and vision. So, it can be quite distressing for folks who have this syndrome. It is a spectrum disorder. For some people, it's more mild. Some people only have the sexual symptoms, and some people, have a full range, and it can really vary in its presentation. So, next slide, please. Prevalence is currently unclear due to underreporting and diagnostic challenges. One study from last year found that 13% of past antidepressant users reported persistent genital numbness after stopping the drug, after using SSRIs and stopping the SSRI. Unfortunately, the study didn't look at persistence of this problem past 3 months. That 13% number could overestimate prevalence. There's a 2023 study from the year before that estimated PSSD risk at 1 in 216. And that study looked at men seeking treatment for erectile dysfunction. So that could underestimate true risk due to the strict criteria excluding people with other dysfunctions or severe symptoms such as genital numbness who didn't seek ED treatment, obviously excluded women and gender diverse people as well. These studies highlight the need for clear diagnostic criteria and additional prevalence research on PSSD. And patients describe experiences of not being believed by clinicians when they do report symptoms, so that also can really affect reporting rates. And limited clinician awareness contributes to further under recognition with symptoms frequently misattributed to depression or other diagnoses. Next slide, please. So as the part of the SHAPE Hub project, we were able to launch a survey of the PSSD community and initiate research projects that are guided by patient priorities. And next slide, please. So after reviewing the existing literature and patient accounts, our team collaboratively worked with affected community members in design development of the survey questions, and the Canadian PSSD Society coordinated the dissemination of the survey to members of the PSSD community. Next slide, please. Persistent distressing symptoms such as genital numbness, anorgasmia, reduced desire and arousal, and sensory disturbances and emotional numbing were found in a high number of people. 96% of participants reported that they received no informed consent about any risks to sexuality at all, let alone PSSD. It's a really common side effect while on the drug, sexual dysfunction. Yeah, what's less well known is PSSD. So severe quality of life impacts were reported. 2/3 reported experiencing suicidal thoughts because of their PSSD. We had participants reporting symptom duration post-drug cessation for over 30 years. And PSSD was reported to be acquired after just brief exposure to the drug of only 2 weeks. 93% of respondents reported both extreme impacts on both their quality of life, and 91 reported extreme or significant impacts on interpersonal relationships, while 64% reported extreme or significant impact on ability to work. The top research priorities identified were treatment development, increased funding, knowledge translation, and understanding of quality of life impacts. And we will have the opportunity to be publishing these results soon, and we'll have more knowledge, medical research to be mobilizing in our SHAPE project. And we've also been able to secure funding for 3 trainee grant projects to study PSSD. And yeah, this is all thanks to the SHAPE Hub.
Thanks so much, Yassi. So that's a great segue into now the 3 trainee presentations. And so indeed, as Yassi mentioned, part of our budget was to have funding to support trainee grants that derive directly from the research priority setting exercises that Yassi just did a great job presenting. So we're now going to hear briefly from the 3 trainees who were the successful recipients of our trainee grant competition. I'm going to invite our 3 trainees to try and keep their presentations to about 5 or 6 minutes max, so that we can have time at the end for question and answer. So Marilyn, we'll hear from you first. Go ahead.
Hi, yeah. So I'm Marilyn. I'm one of the recipients of the Trainee Research Grant, and I work with Dr. Carolyn Pukal at the Sexual Health Research Lab at Queen's University. Next slide, please. So the main objective of this study is to identify and understand which symptoms of PSSD are perceived as most and least disruptive to quality of life, and how these perceptions vary across individuals. So this touches on the first two research questions, and the third research question will be drawing from minority stress theory and biopsychosocial models to determine if demographics, psychosocial, and health factors may correspond to different patterns in symptom distress profiles. Next slide, please. So to answer these questions, we're going to be using Q methodology, which is a mixed methods approach that's designed to capture and categorize patterns in people's subjective experiences. And this is done using 5 steps, which I will explain. Next slide, please. So step 1 is concerning the tool itself, which is called a Q set in Q methodology. And this will include 40 subjective statements that will capture sexual, emotional, cognitive, and relational symptoms of PSSD. And these statements will be drawn from published PSSD literature, patient advocacy groups, and ongoing Shape Hub research. And importantly, these statements will be co-developed with knowledge users to ensure that they're reflecting real experiences and use the most appropriate language. Next slide, please. So we'll recruit about 30 women and gender diverse people who meet PSSD diagnostic criteria. And we'll be using propulsive sampling to ensure diversity across 4 identity axes, so relationship status, racial, ethnic identity, sexual identity, and gender sex identity. And so we will recruit participants using clinic-based recruitment through the Shape Hub and through community partners. Next slide, please. The data collection will consist of online sessions that will last about 90 minutes in total, and they will take place via Zoom. And each session will include 3 parts. The first part being a background survey, the second being the actual Q-sort task, and the third being a semi-structured interview. And I'll give a little bit more detail on these data collection techniques. Next, please. So the background survey will collect demographics, psychosocial, and health information to help us interpret different symptom profiles. Next slide, please. After completing the background survey, participants will then complete the Q-sort task, where we will ask them to sort the 40 different symptom cards along a semi-normal curve based on if they agree or disagree that each symptom applies to their experience of living with PSSD. So for example, if they agree that a statement applies to how PSSD affects their quality of life, they might place it closer to the right-hand side of the grid. If they're neutral or ambivalent about a statement, they might place it more towards the middle of the grid. And if they disagree that a statement applies to them, they would place it more towards the left-hand side of the grid. Next slide, please. So once they've sorted all 40 symptom cards, we'll then complete a semi-structured interview where they'll be able to elaborate on their placement decisions and what each symptom actually means to them. Next slide, please. In terms of doing the data analysis, once we've collected data from all 30 participants, we'll run a Q factor analysis using PQ method software. So this form of factor analysis differs from the standard Spearman factor analysis because instead of correlating items as a traditional factor analysis would, the Q factor analysis correlates people. So each factor will actually represent a shared viewpoint or a group of participants who have ranked their symptoms in similar ways. And these factors will be the foundation for understanding these different symptom burden profiles. Next slide, please. So to interpret the results, we'll integrate both quantitative and qualitative evidence. So from a quantitative standpoint, we'll be looking at the defining items from the different factors. So those that are placed on the extreme ends in the most agree and most disagree sides, as well as the defining items or those that are significantly different across the different factors. And then qualitatively, we'll analyze interview data to understand what these items mean to participants. And so this will help us translate the numbers into these meaningful person-centered insights. Next slide, please. So this study will be the first to define symptom burden profiles in PSSD, and by revealing which symptoms are most distressing and why, it will help us guide clinical support and intervention, improve early recognition of distress, and also inform personalized, person-centered care. We'll also be co-creating knowledge products, so things like infographics, short videos, and plain language summaries with participants and community partners to raise awareness and reduce stigma and make sure that our findings are accessible, respectful, and actionable. So in short, the goal of this project is to amplify patient voices to improve understanding, recognition, and care of PSSD. Thanks.
Thanks so much, Marilyn. We're so excited to hear the results of your project. So we're going to hear from our second trainee from the grant competition, and over to you, Tan.
All right. Hi, everyone. My name is Tan Fung. I am a PhD candidate in Dr. Ashley Monks' lab at the University of Toronto, and I'm really excited to talk to you today about my project, Sex-Specific Neural Responses to Genital Stimulation Following SSRI Exposure and Withdrawal. Before I begin, I want to acknowledge and thank ShapeHub for giving me the opportunity and support to do this research, and as well as for fostering an environment that promotes interdisciplinary collaboration. It's really exciting to see how diverse research perspectives are coming together to shed light on PSSD. Next slide, please. All right. So when it comes to studying human sexual functioning, there's only so much we can do given obvious ethical and practical limits. And that's why animal models, especially rodents, are so useful. I have some advantages listed here on the slide. I won't go over them one by one. However, I do want to emphasize that rodents do actually share a lot of the same hormones, neural circuits, and behavioral patterns that drive sexual motivation and reward as humans. And by studying these mechanisms in rodents, we can start to piece together the biological foundations of sexual behavior and use that knowledge to better understand and eventually improve sexual health in people. Next slide. So with that being said, I've been using mice throughout my PhD to explore the neuroendocrine basis of sexual reward and arousal. My work looks at how gonadal hormones and sensory inputs all interact to shape sexual motivation, both at the behavioral and neuroanatomical level. And in order to do this, we've developed and characterized a model that looks at the rewarding properties of genital tactile stimulation in both female and male mice, essentially looking at how genital stimulation activates hypothalamic and limbic regions in the brain and how that produces states that parallel sexual arousal and reward. A key part of this work involves controlling for circulating hormone levels. So by using gonadectomy and then systemically restoring gonadal hormones, we can precisely determine how hormones such as testosterone or estradiol influences these responses. And what we found so far is that in absence of sex-corresponding gonadal hormones, both behavioral and neuroanatomical indicators of sexual reward disappear in male and female mice. And this shows how important hormonal context is for maintaining the neural and motivational components of sexual behavior. A more interesting finding from my work so far is that in absence of ovarian hormones, we were able to produce a sexual arousal response in female mice through administering systemic testosterone alone. And if we can take a look at the bottom left corner of the slide, we see that manual genital stimulation in testosterone-treated ovariectomized mice produce a genital arousal response, which is characterized by widening of the vaginal opening, also known as the introitus. And this is pretty exciting because most animal models of genital arousal involve anesthetized animals, but we've managed to develop a conscious female model of genital arousal through testosterone treatment and glans clitoral stimulation. And on the bottom right-hand side, we also see an increase in same-sex mounting in response to genital stimulation in the same testosterone-treated ovariectomized mice. And even though this isn't a relatively novel finding in itself, since testosterone has been shown to induce mounting behavior in female rodents, it's actually interesting because in this case, we're able to see this mounting emerge following genital arousal, and that's not something that we've come across yet. Next slide, please. So building on the work that we've done so far, we were able to design an experiment to see how SSRIs can alter these outcomes. There are many behavioral outcomes from SSRI treatments in rodents that parallel human PSSD symptoms. So for example, altered genital sensitivity, reduced mounting behavior, reduced partner approach behaviors in rodents can be correlated to genital numbness, anhedonia, or low libido in humans. And the project that I'll be talking about today is built on the hypothesis that SSRIs inhibit neural responses to genital stimulation, potentially leading to disrupted sexual arousal and impaired reward responses. So in other words, SSRIs may dampen the sensory and motivational processing that normally makes sexual stimulation rewarding. And in order to test this, I'm using a rat model of PSSD developed by Dr. Silvia Giatti and Dr. Roberto Melcangi at the University of Milan, who have shown that chronic paroxetine treatment, which is an SSRI, in male rats leads to clear impairments in sexual behavior that persist even after drug withdrawal. And in collaboration with their team, I'm extending this model to include both female and male rats to see how SSRI exposure and withdrawal alters genital responsiveness and neural activation in brain regions involved in sexual rewards, such as the medial preoptic area, nucleus accumbens, etc. Next slide, please. So here's an overview of the experimental design and methodology. In the study, we'll be treating rats with paroxetine hydrochloride at a dose of 10 milligrams per kilogram per day for 14 days straight. The drug will be dissolved in water and will be administered via oral gavage. And for those who don't know, oral gavage is a precise dosing method where we use a small feeding tube to deliver the drug to the esophagus straight into the stomach. And this bypasses any variability in terms of how much an animal might voluntarily drink or eat. We're also going to have a separate control group that will receive only vehicle, which is plain water, also by oral gavage on the same schedule. And since we're interested in effects of both chronic SSRI use and withdrawal, half of the animals from each group will get treated for 14 days prior to being euthanized for tissue collection, whereas the remaining animals will be euthanized 1 month later after the last paroxetine or vehicle treatment to assess withdrawal effects. And prior to tissue collection, we will conduct standardized genital stimulation trials to see how it is affected by SSRI usage and withdrawal. So this is basically going to involve gently lifting the base of the animal's tail and lightly brushing the glands with a soft bristled brush that's coated with water-based lubricant, warmed to around 30 degrees Celsius. Stimulation is going to be delivered at a rate of 1 stroke per second for 1 minute, and each animal will receive 5 of these stimulation cycles separated by 1 minute intervals. So after this, the brains will be collected and then processed for CFOS immunohistochemistry. Very briefly, CFOS immunohistochemistry is used as an indirect marker of neural activation to map which brain regions respond to genital stimulation. Next slide, please. So to conclude, based on what we know about the effects of SSRIs on sexual behavior, we predict that SSRI treatment will reduce neural activation in key brain regions that mediate sexual responses. So particularly hypothalamic and limbic regions such as the medial preoptic area, which play a role, a central role in sexual motivation and reward. And at the same time, it's also possible that SSRIs may increase activity in neural populations that inhibit sexual behavior too, such as the PVN, also known as the paraventricular nucleus. And beyond these regions, we'll also be looking more broadly across the brain to identify other potential sites involved in PSSD. This includes candidate regions within the brainstem and the spinal cord that contribute to sensory and autonomic components of arousal. And finally, to understand whether these effects persist after drug withdrawal, we'll also be collaborating with Dr. Antoni Shoka at Howard Hughes Medical Institute to explore potential epigenetic mechanisms underlying long-term changes in neural activity and gene regulation. And that concludes my presentation. Thank you all for listening.
Thank you so much, Tan. And now for our last trainee presentation, and actually last presentation of our time together today, the third successful trainee grant awardee, Shay Freger, will let us know about their research project. Go ahead, Shay.
Hi, everyone. My name is Shai. I'm a PhD student at McMaster University. I'm super excited to be here. So if you haven't guessed already, based off the title, my work primarily revolves around endometriosis, chronic pelvic pain. I should note that I'm not doing this work alone. The study really that was being conducted or is being conducted is with our incredible patient partners, as well as our sexual health specialist, Maya Lagat, as well as our master's student, Gail Lopez. So next slide, please. So, giving a bit of an introduction to what actually endometriosis is. So, endometriosis is a chronic pain and inflammatory disease where tissue that is similar to cells that line the inner part of the uterus and up outside the uterus. So, anywhere from the bowel, bladder, ligaments, can even be found the diaphragm, fingernails, and it really affects anywhere between 1 in 10 to 1 in 7 people assigned female sex at birth and gender diverse individuals. And when you look at the endometriosis journey, people with endometriosis typically present in early to late menarche. So when they get their first period with dysmenorrhea or cyclical pain with their period. And then later on, we see some evolution around the 20s and 30s, where we really start to see these things like infertility, of course, and up to 70%, actually, the number is probably now closer, about 80% will experience some kind of deep dyspareunia as well. So pain with intercourse. So, however, patients can present with a whole slew of gynecological symptoms, but most importantly, and also about 100, if not about close to about 150 different complex non-gynecological symptoms. So things like gastrointestinal, urological, MSK, a whole slew of other symptoms, which really complicate that diagnosis and management of the disease itself. So when you look at that left-hand side at a primary care level, only if the disease was really recognized, you hope at a textbook level, a patient presents with 3 iconic symptoms, that dysmenorrhea, infertility, or dyspareunia, which is rarely ever the case, but let's just take it as an example. Typically, patients will cycle through multiple contraceptives, pain medications with or without adequate relief. I think the current number is about 50% of patients will experience some kind of symptom relief using hormonal therapy as of now alone. So after a few cycles, they might get referred to some kind of specialist later on, usually not an OB/GYN. They'll see a GI specialist or they'll see a psych person after that initial referral will be commonly diagnosed as IBS as an example, or even anxiety or depression, really fueling that dismissal of pain and that often onerous journey that's really associated with endometriosis. And finally, after many cycles of the treatments and a bunch of different referrals, you hope that a patient reaches an OB/GYN, where you'd hope they get answers, that adequate management, great diagnostics, only to find out that there is no cure. And the diagnostics aren't always perfect, and no one really knows what causes endometriosis, even to this day, all of which takes anywhere between 2 to 25 years. So the diagnostic delay from that initial onset at menarche to the day they get their diagnosis and the first sort of management could take anywhere between 2 to 25 years. I think the average is about 5.6 to about 10 years in Canada. And it sounds bleak, I know, and it really is bleak. Endometriosis is one of the most debilitating diseases and one of the largest health system failures to this date. At this current time, I believe it's about estimated that up to 87-ish% of patients will experience depression, and about 98.5 will experience some kind of anxiety-like symptoms. So next slide, please. When you dissect that a bit further, if we take a step back after repeated dismissals, whether it's by family, loved ones, friends, and even clinicians, which is more often than I'd care to admit, happens all the time, alongside those massive impacts on quality of life, everything from not being able to go to school or work, losing thousands of dollars in finances monthly, yearly, and not being able to hold your own child, go out to social events just in fear of having a flare up. All of these things really compound on top of those pathological mechanisms, like things like inflammation and nociceptive pain. Endometriosis, although there's a lot of debate as to whether the disease itself evolves over time, the symptoms do evolve. We know that much. So in response to that cyclical pain at menarche and over dozens of other pathological mechanisms, the body rewires itself essentially through a process called central sensitization, where the body will react in a state of survival in response to things that might not even be noxious, like pain and inflammation. It could be things like touch, or the food you just ate could be perceived as pain. So when we look at the systems that really drive that change, of course, the central sensitization, the central nervous system, that's quite obvious. But another massive component to it is the autonomic nervous system. It's one of my favorite things to talk about. I love the autonomic nervous system. It's the master regulator, or the puppet master of our body, controlling essentially every unconscious decision our body makes. Everything from urinary and GI movements, heart rate, sweating, pupil dilation, all of those things are regulated by the autonomic nervous system. And when we dissect that a bit further, the system's divided into two components. You might be familiar, I'm pretty sure most of us are probably familiar with fight or flight. That's the sympathetic nervous system. Then there's rest and digest, the parasympathetic nervous system. And they're in this constant state of balance with each other, maintaining that homeostasis. So what if we, I don't know, what if we piss off the puppeteer one day? You know, whether it's noxious stimuli, inflammation, constant pain, even psychosocial factors, stress, daily stress we can experience. The body, it doesn't matter whether it's myself, the people in this room, or people with endometriosis, have a horrible ability at differentiating between things that are just life inconvenient and life threatening. Whether you're stuck in traffic on your way to work this morning, or I'm sprinting out of some kind of fiery building, the body will react in very, very similar ways. It's not very well adept to controlling those things. And that's really
Shai, sorry to interrupt. Just in light of time, I'm hoping you can just wrap up by letting us know the PSSD project, and then we'll have maybe 1 minute for questions. Sorry to rush you through.
no, happy to. So let's go to the next slide. We can jump right into the main objectives. And really the whole point of the study is to really look at that overlap between endometriosis, that evolution of chronic pelvic pain, and PSSD, and really look at the variable factors that really compound each other and lead to a lot of those autonomic nervous system-like symptoms and really drive pain mechanisms in endometriosis. So again, comparing to things like quality of life, patient-reported outcomes. Next slide, for the sake of time, I'll jump right through. So there are 3 primary phases to the study. It is a pilot study. We're hoping to recruit about 40 participants. And we have 4 different groups, so 10 patients per. And there are the 2 phases essentially, or the 2 primary phases will be a clinical exam, so physical exam where we try to pinpoint the various pelvic floor muscles, look for deep dyspareunia, look for superficial dyspareunia as well. And then with our new patient partner, there's a suggestion to introduce a phase 2, which is an arousal assessment essentially. So taking home various medical devices that we're also using for the clinical portion to measure essentially top-down and bottom-up processes of the nervous system and essentially look at how it's affected. And then there's a qualitative component where we're taking about 4 participants per group to really paint that picture of the impact with the medical system, how it's impacted their quality of life, and really paint that beautiful picture. So next slide, I guess. Yeah. And so why do we really care? What's the so what? So the idea of the study is really to provide that preliminary evidence to support larger studies. Of course, it is a preliminary study and really help developing triaging tools to categorize and diagnose the impact of that sexual dysfunction beyond those self-reported questionnaires we use every day, and create tools for both patients and clinicians, really improving the care among millions of patients. Thank you.
So as you can see, we're really excited about these trainee presentations. Sundus, I'm going to ask you to fast forward to the second to last slide, please, so we can wrap up and you can see our call to action. One before that, please. So we invite you to follow us, follow our websites, join our newsletter, become a part of the SHAPE portal, where we can update you on the many other initiatives as these 3 incredible trainees undertake their research and have results. We'll be sure to share that with the community. We would also love feedback. So for anyone who's attending today or watches the recording afterwards, let us know. Let us know other ways that we can help fill the gap in addressing this critically underserved community, this critically under-researched topic area. And for all of you who presented today and all of you who joined in, thank you so much for your time and attention. Again, huge thanks both to Kaku Lema, who's our Knowledge Mobilization Manager, and huge thanks to CIHR, IGH, and WAGE for the funding. Thanks, everyone.
Amazing. Thank you so much, Lori. Thank you so much to all our presenters. What a action-packed and information-packed hour that was. I know there's areas I'm going to want to go back and check out again. So thank you so much for sharing all that information. And as was mentioned, please reach out directly with any questions that you have, or feel free to send them our way at CanWatch, and we'll make sure that they get to Lori and the team. Again, posted here in the chat are links to our next ground round. If you loved this conversation, definitely join us next month for a conversation, this one with the Healthy Pregnancy Hub. Click on that link to learn more. and to sign up. And also, on the off chance that you might miss this one or you want to make sure to get the links, the best way to do that is to sign up for the Pan-Canadian Women's Health Coalition newsletter. The link to that is also in the chat, so sign up and you'll get notified whenever these recordings are posted or whenever we have a new session coming up. So once again, tremendous thanks to our presenters. Thanks to you for joining us, and we'll see you next month at the virtual Grand Rounds. Bye for now.